The inguinal region or groin extends between the anterior superior iliac spine and pubic tubercle. I'm going to draw the anterior superior iliac spine here, and here I'm going to draw the pubic bone. This is the site of the obturator foramen. So here we have the superior ramus of the pubis, body of the pubis, and inferior ramus of the pubis. This is where the pubic symphysis is located. On the superior ramus of the pubis, this is the site of the pubic tubercle. Between the pubic tubercle and the pubic symphysis, the crest of bone is called the pubic crest, and lateral to the pubic tubercle, this region is called the pectineal line of the pubis. The inguinal ligament extends between the anterior superior iliac spine here and the pubic tubercle. I'm going to draw it as two lines here because the inguinal ligament is a thickened lower free border of the external oblique aponeurosis. This aponeurosis is not sharp inferiorly because the aponeurosis is upturned on itself, so it becomes blunt. Some fibers of the inguinal ligament will be reflected backwards and attached to the pectineal line of the pubis, and these fibers will constitute the lacunar ligament. Some other fibers extend laterally from the lacunar ligament over the pectineal line of the pubis, and these produce the pectineal ligament. There is another extension from the inguinal ligament, and these fibers are deep fibers that extend upwards and medially. As you can see them here, I will draw them dotted. These extend upwards and medially. They cross the midline, the linea alba, and they constitute what is called the reflected part of the inguinal ligament. The aponeurosis of external oblique muscle has a deficiency in it. This is the site of the deficiency. In fact, it's a triangular deficiency and is called the superficial inguinal ring. The name is a partial misnomer because although it is superficial and located in the inguinal region, but it is not in the form of a ring. It is rather triangular in shape. Its apex is directed upwards and laterally, and its base is formed by the pubic crest, and it has two borders, medial border and a lateral border, which are formed by the crura, medial crus and lateral crus of the aponeurosis of external oblique muscle. Now I'm drawing the fibers that constitute the medial crus, and there are other fibers here that constitute the lateral crus of the aponeurosis. In addition to the medial crus and lateral crus, there are some other fibers that run perpendicular at the apex of the superficial inguinal ring, and these fibers, they constitute intercrural fibers. They help to prevent the crura from spreading apart. Also located in the inguinal region is the deep inguinal ring, and this deep inguinal ring is a deficiency in transversalis fascia that is located just above the midpoint of the inguinal ligament. So let's draw the inguinal ligament again. This is the anterior superior iliac spine, pubic tubercle. Again here I am drawing the inguinal ligament extending between the anterior superior iliac spine and the pubic tubercle. Midway between the anterior superior iliac spine and the pubic tubercle is the location of the deep inguinal ring. This is a true ring, a deficiency in transversalis fascia, and located midway between the anterior superior iliac spine and the pubic tubercle. Now I will project the superficial inguinal ring again here, which is a deficiency in the external oblique aponeurosis. Between the deep ring and the superficial ring is the inguinal canal. So this is the proposed location of the inguinal canal. It is an intermuscular canal that extends between the deep inguinal ring and the superficial inguinal ring. It is located above and parallel to the medial half of the inguinal ligament, and is about 4 cm in length. Structures that pass through the canal, including the ilioinguinal nerve in both sexes, the spermatic cord in the male, and the round ligament of the uterus in the female, they have to traverse other layers of the anterior abdominal wall that participate also in the formation of the inguinal canal. So up to now we have mentioned that transversalis fascia and its deficiency produces the deep inguinal ring, and the aponeurosis of external oblique muscle produces the superficial inguinal ring. So what about the transverse abdominis muscle and the internal oblique muscle, which are located in between the external oblique and the transversalis fascia? Now let's complete the diagram on the other side. The inguinal ligament provides attachment to muscle fibers. Actually, it provides attachment to the muscle fibers of transversus abdominis and internal oblique muscle. Here I'm going to draw the origin of transversus abdominis muscle from the inguinal ligament. The fibers of the transversus abdominis arise from the lateral third of the inguinal ligament. Some anatomy textbooks mention that they arise from the lateral half of the inguinal ligament. Whatever the origin, these fibers do not pass in front of the deep inguinal ring and therefore do not contribute to the anterior wall of the inguinal canal. The lowermost fibers of the transverse abdominis muscle, they arch down and become tendinous. These fibers are attached to the pectineal line and to the pubic crest. Those arching fibers constitute part of a ligament here, which is called the conjoint tendon or falx inguinalis. Some of these fibers curve medial to the deep inguinal ring and constitute a thickening here that forms a physical boundary of the deep inguinal ring, and these are called interfoveolar fibers. Now let's deal with the other layer that contributes to the formation of the inguinal canal, and that is the layer that is formed by the internal oblique muscle. Again, I'm going to draw the inguinal ligament. This is the inguinal ligament extending from the pubic tubercle to the anterior superior iliac spine. Apart from transversus abdominis muscle, the inguinal ligament provides attachment for another muscle, which is the internal oblique muscle. These are the internal oblique muscle fibers. They arise from the lateral 2/3 of the inguinal ligament. Now remember that the deep inguinal ring that I am approaching now is located midway between the anterior superior iliac spine and the pubic tubercle. Therefore, this muscle, which arises from the lateral 2/3 of the inguinal ligament, is located in front, partly in front of the deep inguinal ring. Thus, this muscle contributes a sheath to the contents of the inguinal canal, while the transverse abdominis muscle, which does not lie in front of the deep inguinal ring, does not contribute a sheath to the structures that pass through the deep inguinal ring. Like the transversus abdominis, the lowermost fibers of the internal oblique muscle, they curve as well, and they constitute the other part of the conjoint tendon. These curving lower fibers are attached to the pectineal line of the pubis and to the pubic crest. Now I'm going to project the superficial inguinal ring again. Now by using these diagrams we can list the boundaries of the inguinal canal. Just to remind you, this is the most superficial diagram showing the superficial inguinal ring and the aponeurosis of external oblique, and this is the deepest level of the diagram, which shows the transversalis fascia and the deep inguinal ring, and then this deepest layer is covered by another layer of the transversus abdominis muscle, and then another layer of the internal oblique muscle, and returning back to the most superficial layer, which is formed by the external oblique muscle and its aponeurosis. So the anterior wall of the canal is formed by the external oblique aponeurosis here, and it is reinforced laterally by internal oblique fibers that arise from the lateral 2/3 of the inguinal ligament. Again, I repeat that the transverse abdominis muscle that arises from the lateral third or lateral half of the inguinal ligament does not pass in front of the deep inguinal ring and therefore do not participate in the formation of the anterior wall of the inguinal canal. The roof of the inguinal canal is produced by these arching fibers of the transversus abdominis muscle and the internal oblique muscle. These fibers, they arch from anterior to posterior. They form the roof. They form also the posterior wall of the canal. So here we can find that the posterior wall of the canal is formed by the transversalis fascia here, and it is reinforced medially by the conjoint tendon, which is formed by the internal oblique muscle and the transversus abdominis muscle, as well as reinforcement by the fibers here, the reflected part of the inguinal ligament, the fibers that extend upwards and medially from the inguinal ligament. So these form the posterior wall of the inguinal canal. The inferior epigastric artery ascends in the posterior wall of the inguinal canal, medial to the deep inguinal ring, as we will see later. The floor of the inguinal canal is formed by the undercurving fibers of the inguinal ligament and the lacunar ligament, as well as a thickening of the transversalis fascia, which is located deep and parallel to the inguinal ligament. This thickening is called the iliopubic tract. The inguinal region is an important area anatomically and clinically. Anatomically, it's a region where structures, they exit and enter the abdominal cavity, and clinically because the pathways of exit and entrance are potential sites of developing hernias. So here we have the inguinal hernia, and close to the inguinal ligament also we have the femoral hernia might develop. To better understand the inguinal region and where the hernias pass, let's examine the inguinal region from the inside, in other words, from the inside of the abdominal cavity. Now I'm going to draw the inguinal region from behind. This is again the anterior superior iliac spine, and here this is the superior ramus of the pubis, pubic tubercle, pubic crest, and the pubic symphysis, and here's the inferior ramus. And this is the site of the obturator foramen. Now I will draw the inguinal ligament again, but from behind, extending from the anterior superior spine to the pubic tubercle. Here's the site of the deep inguinal ring. Now this is the rectus abdominis, lateral border of rectus abdominis muscle. Here's the site of the linea alba, and those are the fibers of the rectus abdominis muscle as they are attached to the pubic crest. Now these fibers, they constitute the lacunar ligament. They are reflected from the inguinal ligament, and this is the pectineal ligament here. Now midway between the anterior superior iliac spine and the pubic symphysis is the site where the external iliac artery is located, and its continuation, which is the femoral artery. So this is the external iliac artery. Here the external iliac artery and its continuation, the femoral artery, are a little bit medial to the site of the deep inguinal ring, because they are located midway between the anterior superior iliac spine to the pubic symphysis, and this is a longer distance than the midway between the anterior superior iliac spine and the pubic tubercle. The external iliac artery, before passing deep to the inguinal ligament, it provides a branch which is the inferior epigastric artery. This is the inferior epigastric artery. It goes upwards and medially toward the back of the rectus abdominis muscle to enter the rectus sheath. During its course, it lies therefore in the posterior wall, and as you can see, it is located medial to the deep inguinal ring. It forms a boundary of an important triangle here. This triangle is called the inguinal triangle, or triangle of Hasselbach. This is the triangle where a direct inguinal hernia might pass. The triangle is bounded by the inferior epigastric artery laterally, the lateral border of rectus abdominis muscle medially and inferiorly by the inguinal ligament. Now let's add more details to this region. So I'm going to draw the transversus abdominis muscle, and as has been mentioned earlier, that it arises from the lateral third or lateral half of the inguinal ligament. So these are the fibers of the transversus abdominis muscle. The lowermost fibers, they arch down and they are attached to the pectineal line of the pubis, and they constitute part of the conjoint tendon. This conjoint tendon that strengthens the medial part of the inguinal canal. Those arching fibers, while doing so, they form part of the floor of the inguinal triangle. The lateral part of the triangle here, which is not strengthened by the conjoint tendon, is formed by the transversalis fascia alone. Weakness of the floor of this triangle can predispose to a hernia. This hernia can push itself from the abdomen forwards into the inguinal canal without passing through the deep inguinal ring. A hernia that passes through the deep inguinal ring goes into the canal and appears through the superficial ring again is called an indirect inguinal hernia. A hernia that pushes itself through the posterior wall of the inguinal canal in the region of the inguinal triangle and appears through a superficial inguinal ring is called a direct inguinal hernia. Now let's draw some more details in this diagram. Medial to the external iliac artery is the external iliac vein. More medially, here there is a deficiency in the anterior abdominal wall. This deficiency is bounded anteriorly by the inguinal ligament, medially by the lacunar ligament, posteriorly by the pectineal ligament or the pecten pubis, and medially by the external iliac vein or the femoral vein distally, and those boundaries, they constitute the boundaries of the femoral ring. Through this ring, a hernia might push itself from the abdomen into the femoral triangle, and this is called the femoral hernia. Now I'm going to add some more details to this diagram. Passing through the deep inguinal ring is the vas or the ductus deferens. And this vas or ductus deferens will cross the inferior epigastric artery in its way into the pelvis. The inferior epigastric artery supplies a small branch here that goes with the vas, and this is called the cremasteric artery. The vas, in its way from the abdomen into the inguinal region and the testis, is accompanied by another artery, which is a branch of the inferior vesical artery, and this is the artery of the vas or ductus deferens. There is another artery here, which is a main artery that supplies the testis, and this is the testicular artery. Those arteries, together with the vas and together with the veins and lymphatics and nerves, they are going to acquire sheaths during their passage through the inguinal canal. The first sheath that they acquire is while passing through the transversalis fascia, and this is called the internal spermatic fascia, that is derived from transversalis fascia. Then the contents of the spermatic cord pass forwards and medially in the inguinal canal. Transversus abdominis muscle does not contribute to a sheath because its fibers do not pass in front of the deep inguinal ring. But the internal oblique muscle, whose fibers pass in front of the deep inguinal ring, will contribute to the spermatic cord another sheath, and this sheath is called the cremasteric fascia. This sheath, in fact, is not only a fascial sheath but contains muscle fibers derived from the internal oblique muscle, and these muscle fibers are called the cremaster muscle fibers. As the contents of the spermatic cord pass through the superficial inguinal ring, they will acquire another sheath from the aponeurosis of the external oblique muscle, and this is called the external spermatic fascia. An important point to show here in relation to the femoral ring is the pubic branch of the inferior epigastric artery. This pubic branch passes in relation to the femoral ring and the lacunar ligament toward the superior ramus of the pubis. This artery passing toward the obturator foramen is the obturator artery. And before it passes through the foramen, it supplies a pubic branch as well to supply the bone. Now this pubic branch anastomoses with the pubic branch of the inferior epigastric artery. Sometimes the obturator artery is absent. The proximal part of the obturator artery is absent, and the pubic branch of the inferior epigastric artery becomes large and replaces the proximal part of the obturator artery, continues through the obturator foramen into the thigh. Now this large branch here is called the abnormal obturator artery. It should be kept in mind because surgical operations at this region dealing with the lacunar ligament and the femoral ring might injure this abnormal artery, abnormal obturator artery, and result in considerable bleeding. Now, to better understand the inguinal hernia, I would like to remind you of some embryology related to the development of the testis. This is a diagram showing a sagittal section in the body, the scrotum, the penis here, and the anterior abdominal wall. Pubic symphysis here. The testis, actually the gonads, whether testis or ovary, they develop in the posterior abdominal wall, behind the peritoneum. This is to show the peritoneal cavity here. And the gonad is connected to the perineum by a band of fibrous tissue. So here in the male, it is connected to the site where the scrotum is going to be formed. In the female, the counterpart of the scrotum is the labium majus, so it is connected to the labium majus. Further growth results in the descent of the testis along this fibrous band, which is called the gubernaculum. And this fibrous band has to pass from the abdomen through the anterior abdominal wall in order to reach the perineum. During its passage through the anterior abdominal wall, it passes through the inguinal canal, from the deep inguinal ring to the superficial inguinal ring in its way to the scrotum. The ovary does not reach the labium majus, and its descent will be halted in the pelvis. The remaining part of the gubernaculum in the female, therefore, will constitute the round ligament of the ovary and the round ligament of the uterus. The round ligament of the uterus is therefore located in the inguinal canal of the female. During the descent of the gonads, a tubular prolongation from the peritoneum grows down into the perineum. This is called the processus vaginalis. The processus vaginalis therefore passes through the inguinal canal. With further development, the proximal part of the processus vaginalis will become obliterated, and only the distal part of the processus vaginalis remains in relation to the descended testis, and this remaining part of the processus vaginalis is called the tunica vaginalis. Failure of obliteration of this segment of the processus vaginalis will make it continuous with the peritoneal cavity and create a potential site for a hernia to take place. This hernia is therefore congenital hernia, and this hernia therefore passes from the deep inguinal ring to the superficial inguinal ring. So it is an indirect hernia. This hernia is more likely to occur in the male because it is related to the descent of the testis. And this hernia usually descends and extends into the scrotum. A direct inguinal hernia is less common than the indirect hernia, and it is also called acquired hernia because it results from the weakness of the posterior wall of the inguinal canal, the inguinal triangle of Hasselbach. This weakness is common after the age of 40 years. In contrast, to the indirect inguinal hernia, which usually occurs in young males because it has congenital origin. In the direct inguinal hernia, the hernial sac protrudes directly forwards without passing through the deep inguinal ring. It passes directly through the superficial inguinal ring. Now let's sketch the sites of these hernias and their relations. Here's the femoral artery located midway between the anterior superior iliac spine and the pubic symphysis. The external iliac artery, which is proximal to the inguinal ligament, provides a branch which goes upwards and medially, and this is the inferior epigastric artery. So you can see the inferior epigastric artery traverses the posterior wall of the inguinal canal, medial to the deep inguinal ring. Medial to the femoral artery is the femoral vein, and at this location, these are the fibers that constitute the lacunar ligament, and then the pectineal ligament, and this is the deficiency here, the femoral ring leading into the femoral canal, medial to the femoral vein, is bounded anteriorly by the inguinal ligament, medially lacunar ligament, posteriorly pectineal ligament. An indirect inguinal hernia that is predisposed by a patent processus vaginalis passes through the deep inguinal ring. So the neck of the hernia is in fact located lateral to the inferior epigastric artery. A direct inguinal hernia that passes through the Hasselbach triangle because of weakness of the posterior wall of the inguinal canal passes medial to the inferior epigastric artery. In both cases, the hernia passes through the superficial inguinal ring and is located, as you can see here, located upwards and medial to the pubic tubercle. A femoral hernia, on the other hand, that passes through the femoral ring, extends into the thigh, into the femoral triangle of the thigh through the femoral canal, and as you can see that it is located downwards and lateral to the pubic tubercle. So an indirect inguinal hernia is more common in a young male because it is predisposed by a processus vaginalis that accompanies the descent of the testis. A direct inguinal hernia is more common in elderly after the age of 40 because it is predisposed by weakness in the posterior wall of the inguinal canal. A femoral hernia, on the other hand, is more common in females because in females who have wider pelvis therefore have wider femoral ring, and therefore femoral hernia is more likely to occur through a wider defect, and therefore it's more likely to occur in females.